Hello, everyone. Thank you for taking the time to watch this recording on the nutrition care process. I'm very excited to go over this with you and get a good understanding of how we as dietitians, let's put on our dietitian hat, can help support the outcomes of those that we interact with by using the nutrition care process, or NCP. So we'll do a big overview of what the NCP is, but this semester we'll be using the NCP as framework to help us approach different cases and think of ideas of what the problem is, how we can assess for those problems, how we are going to diagnose that problem using nutrition diagnostic terminology, and then how are we going to treat that problem, monitor and evaluate that problem. So this is hopefully going to be a great framework for us as we move forward throughout this semester. And since this is a Zoom recording, we hopefully can refer back to this if need be for support in the future. So for the nutrition care process, right, nutrition does matter. So we have this framework because nutrition care, we are the nutrition experts on a person-centered healthcare team where our healthcare systems are relying on dietitians to be experts in the treatment and support of many different diseases, right? So nutrition or lifestyle related diseases include some of the major causes of death or major causes of concern for folks entering the healthcare system. So folks with heart disease, diabetes, cancers, all of those are potentially lifestyle related. Deficiencies and toxicities may have some nutrition, definitely, right, have nutrition things going on there. Inflammation could be caused by nutrition, could be prevented by nutrition, right? We, as dietitians in the hospital, are always screening for malnutrition and helping to prevent malnutrition that could occur while patients are in the hospital. And then, right, we are experts in nutritional needs throughout the life cycle, or what we will be developing as a class, learning about those needs and how they vary depending on stage in life. RDNs specifically are really, really important, right? Because we are those nutrition experts. We know how to collect nutrition data and interpret that data. And better yet, evidence suggests that when a dietitian is on a healthcare team, there are better patient outcomes. So it's not only that we exist in the healthcare system, but as dietitians, when we are providing care to patients, patients end up leaving the hospital a lot healthier and a lot better off. And that's just another reason why we as dietitians need a tool, standardized tool, such as the nutrition care process, that can help us provide that important care that has been identified in the research. So again, this is the nutrition care process, or NCP. It is a standard process, but it's a standard process that allows us to give individualized care. So if we look at this diagram, we have potentially different ways to hear about or get connected with a patient, right? So there's screening or referrals that could happen where a risk was identified and we are getting called in to provide an assessment, to provide care. And so this is pinging us to the nutrition care process. And then within this standardized methods, we want to be, considering these larger systematic effects, right? So we have where are we working, what is the healthcare system like, what are the economics, and then how are nutrition, dietetics knowledge, collaboration skills, things like that, how are these all interacting? But when it comes down to it, the NCP is a template for the ADIME note, or the process that we must all go through when approaching a client that we've either been referred to or been requested to do a screening for. So ADIME is an acronym. It stands for Nutrition Assessment, or that A part of ADIME. D is the nutrition diagnosis that we provide based on our assessments. And then we have the I, or nutrition interventions. So these are the interventions that we deem appropriate based on our nutrition diagnosis. And then the final quadrant is that monitoring and evaluation piece, where we identify different indicators that we will follow up on and continue to monitor in order for that goal to be achieved, right? So this is the nutrition care process, NCP. And broadly, these are the steps. So ADIME, assess, diagnose, intervention, monitor, and evaluation. So some history, right? Before the nutrition care process was finalized, standardized, and widespread, there were various antiquated methods of note-taking for dietitians in the clinical setting. So prior to ADIME, there was something called SOAP notes, which is there's some basis of SOAP notes in ADIME. They're similar in some aspects, where with the assessment portion of ADIME, you are collecting subjective and objective data, but ADIME is way more in depth compared to these SOAP notes, where we're noting down subjective things, objective things, some notes from our physical assessments, and then a plan. So you can tell from here, right, this is really, really broad. The SOAP notes, people were commonly writing these down on paper. There was no electronic health system with note-taking. And so we've moved into the modern era where we are taking notes, sharing them on healthcare teams. We are providing in-depth, individualized plans of care. And all of these language and standardized formats was established in 2003. So since then, right, we can use the NCP to get these diagnoses and assessments and then treatment plans to our patients in an individualized manner. So that first part that like pings dietitians to doing the NCP, right, is through a screening process. So we may be referred, we may be pinged due to some sort of screening. And so in the clinical setting, right, we could be asked to do a assessment due to an identified malnutrition risk. So there are some examples in Moodle if you just follow my clicks, right? So if we go to the Moodle page under nutrition care process, there are a couple different ones. So there's types of nutrition screens. If you click that, that brings you to the evidence library. And basically, right, this provides us with an overview of the different nutrition screens that are available. So if I click on NSA tool descriptions, this breaks down the literature for me, so I don't have to read a million studies, but we'll tell you about these different malnutrition screening tools, why they might be good, who they're good for, etc. So we have a couple different screening tools at our disposal, but essentially, right, they're all used to identify malnutrition. In addition to this resource, I also have uploaded this mini nutritional assessment. This has been deemed the most appropriate for adults over 65 for identifying malnutrition risk. So here is what the assessment looks like. If we look at the elements that are included in this assessment, we're asking the patient, has food intake declined over the past 3 months? Is there loss of appetite? Do you have digestive problems? Are there chewing and swallowing difficulties? So here we are asking or checking notes to see what the status is on this question and then giving it a grade. We're checking for weight loss trends. So if we are seeing significant weight loss, right, we would give it a certain score compared to weight loss that maybe hasn't occurred. Mobility differences. So we're assessing maybe from notes or maybe from observations of the patient again, right? Are they mobile? Can they move? Are they chair bound? We're looking about stress or acute disease. These things can also lead to changes in weight and malnutrition. So we're checking that. And then we're looking at BMI. Is their BMI classified in that we're in that really low BMI range where we would have some maybe nutritional concerns there? Importantly, right, we can have malnutrition without a low BMI, but this is just another way that we can catch malnutrition. So we add up all of our points here, and then it tells us, right, are they at risk for malnutrition? Are they malnourished? Or do they have a normal or adequate nutrition status based on this screening? So screening tools like this may be used in order to identify malnutrition, to ping a consult from a dietitian, or can be used by a dietitian that maybe was referred to a patient to identify if malnutrition is something that is of concern prior to interacting with that patient, or after the fact, where we're identifying malnutrition and getting the appropriate interventions to that patient to avoid the consequences of malnutrition, right? So we can be pinged to do a consult, right, due to malnutrition risk. We can also just be pinged for any other reason, or just be working on, right, a floor where we are typically utilized and can do those consults. So we have self-referrals, referrals from other healthcare professionals, and then, right, we can be asked to do a consult based on a malnutrition screen. So these are all reasons why we might initiate the nutrition care process where our services are specifically needed. So when we are doing our assessment, right, we need to collect a lot of data in order to make an informed nutrition diagnosis and an appropriate nutrition intervention. So we have lots of tools at our disposal to assess nutrition status. And it's not something like, right, you go into a room and you can tell immediately that nutrition is needed, right? So make sure that we are being thorough in our assessments. We are looking past just first glance, we're investigating, we're asking questions. And when we're doing the nutrition assessment, we're using the ABCs of nutrition assessment to really guide this process and lead us to an informed nutrition diagnosis. So you might be asking, right, what are the nutrition assessments ABCs? So they help us look past our first looks and really investigate what's going on. So we want to collect data in all of the areas of the ABCs. So A, anthropometrics. These are body measurements, right, that we might be collecting. They may exist in the chart. Wherever they're coming from, we want to include them, right? We're looking at labs for that patient. That's the B portion, the biochemical analysis. The C is our clinical and physical evidence and client history. So this might be gleaned from your interaction with the patient. What are they reporting? Or it could be gleaned from the note, what was noted a few months ago, what are the trends, what's happening with the client. And then the D is dietary. So most importantly, right? How are they eating? What are they eating? How is their appetite? How is their swallowing? Things like that. So we're going to break down the ABCs and what that looks like in the next few slides, just so we can really get a sense of this nutrition assessment portion, or the first step in the NCP. So nutrition assessment, this tool is really great. So this is the NCP Pro Nutrition Assessment Snapshot. It's linked on the Moodle page, but if you want to click the link here, right, it takes us to a link where we are getting some specific lingo and some specific guidance provided by the Academy of Nutrition and Dietetics, right? So when we're looking at nutrition data, right, we start with the A part, or the anthropometric measurements. So this is specifically like detailing for us what specifically in this category is important to us as RDN. So we want to look at weight, we want to look at height, we want to look at frame, BMI, changes in weight, body compartment assessments, etc. So this snapshot is really, really great as a guide to know exactly what we are looking for within each category of assessment. So, right, we have this snapshot here available to us. But if we sneak back here, right, we want to be looking at all sorts of things. So it's listed out on the snapshot, but right, we maybe will ask them for a 24-hour recall, or ask them how their diet has been going, if they have any food preferences, what normal eating looks for them. We want to know about their capabilities or their mobility. We want to collect basic anthropometric data again. We want to know basically as much as we can about the medical problem or why they are with us, right? And then we want to look at other like underlying influences that could be impacting their nutritional status. So what is their family history? Do they have a risk for certain diseases or not? Are they working? What kind of work do they do? Other lifestyle factors, like how much are they getting out of the house? Do they have friends? Are they happy? Or do they have mental health concerns? All of these factors are really, really important assessment data that is summarized right in this snapshot resource. But for the anthropometrics, we are collecting physical data. We may not be the one collecting it, but we want to look at everything we can that describes how the body is doing, right? So we want to look at how tall they are. Typically in adults, this does not change very much, right? So if it says 5'6" in the chart, maybe we don't need to check their height when we're with them, right? Their weight and weight history, very, very important. So we're looking at what is their weight right now, but what has their weight look like over time? Do their pants fit tighter now than they did before, or looser now than they did before? Some people don't weigh themselves every day, and so using language like that could help a patient describe changes in weight that maybe they're not seeing because of the numbers, but have observed because of the way their clothes fit. We're maybe looking for changes in head circumference. Certainly that's applicable with infants. And then we're looking at BMI. BMI is not a great marker, but it does tell us something. So BMI is still very, very important to us in the clinical setting. And then we can look at different ways to quantify body fat. So we can look at body fat on various parts of the body using our nutrition-focused physical exam skills. For malnutrition, we are always assessing for malnutrition because we want to avoid malnutrition related concerns, right? So malnutrition can be experienced acutely, can be subacute, and it could be chronic. And there's overnutrition and then there's undernutrition. So undernutrition rate is when we're not getting enough nutrition. And likely with the screenings, right, we are looking at both biochemical data. So inflammation could be a signal of malnutrition. We can look at changes in body composition and mobility. So that was in that screening tool, but we can also screen for some of those things with our nutrition focused physical exam. And then typically, right, our malnutrition is caused by 3 different categories. So one, starvation related, that would be intake related, so not taking in enough food. Chronic disease related, so chronic diseases can cause wasting or weight loss. And so that's something that can happen. Same with acute injury. Sometimes acute situations or injury can increase our metabolism. So it's really difficult to get in enough nutrition, which can lead to malnutrition. So there's these 3 categories that generally malnutrition falls into. But when we're assessing, we want to always assess for malnutrition by considering these things. And so, right, we can use different tools. This is another example of a tool where we're taking a peek at how much they're taking in. We're looking at weight loss trends. We're looking for changes in fat loss, which we will identify through the nutrition focused physical exam. We're looking for changes in muscle mass, maybe fluid accumulation or swelling data that is in the chart or evidenced in our interactions with the client. And then we can use grip strength also to identify malnutrition. So this is particularly relevant in older adults, but if their grip strength is significantly reduced, right, this could indicate muscle wasting. This could indicate that they are not well nourished. So these are all tools, again, that can come from acute scenarios and chronic scenarios and be classified into moderate or severe categories of malnutrition. Okay, so that's A. We've assessed the anthropometrics, right? So our B of the ABCDs of assessment is biochemical markers or biochemical analysis or labs, right? So those are all the same, different names for the same thing, but we want to look at their labs. So we want to, when we're looking at labs, remember that there is a difference in fasting versus non-fasting labs, but we want to look at as much of the lab data as possible and really look for things that are red or are flags, right? So we are going to be looking at blood counts. We're going to be looking at the urinalysis. We're going to look at the renal labs, how well their kidneys are functioning. We want to screen for anemia. And maybe other sources of anemia that are outside of iron, right? Because we know that B12 and folic acid can also cause anemias. We want to look at how well their liver is functioning, because remember, the liver is our most metabolic organ, very, very important. We want to make sure that we're screening for diabetes. Are they diabetic? Do they know they're diabetic? Are they acting like they're diabetic? All of these things can come from that labs. We want to make sure that we know about any cholesterol concerns or cardiovascular health concerns. And then because the thyroid also has such an influence over metabolism, we also want to be checking the thyroid labs. And again, when we're looking at these labs, right, sometimes we're having to glance over them really quickly before we see the patient. But we really, really, really want to be looking at the snapshot of the labs, but we want to look at what those labs are doing over time, right? Are these labs trending one way or the other? Are they improving? Are they stable? Are they really increasing all of a sudden? And then we also want to think about, right, why are these things happening? So it's not just that your triglycerides are high, right? Your triglycerides are high and your glucose is high. What does this mean in terms of disease state? And then what does this mean, right, in terms of what we do nutritionally? So if I saw high triglycerides and high glucose, I might think to myself, maybe this person is insulin resistant, maybe they are pre-diabetic, maybe they are diabetic, right? So I would check these labs against maybe some client history and see if that diagnosis already exists. And if it doesn't, maybe that's an area where I get to provide education as a part of my intervention part. So biochem analyses are super, super important and can help us piece together the puzzles of our nutrition diagnosis ultimately. So what's happening anthropometrically, what's happening in our blood. These are all pieces of the puzzle that help us figure out what's going on and how we can help as dietitians. That C part of the ABCD, part of it is about clinical data. And so again, this is data that is relevant to what's going on with the patient nutritionally. So we want to look at clinical history and physical data. So do they have a history of diagnoses that could impact nutrition? So do they have GERD? Have they had something happen with their GI? Do they have a disease that causes wasting, for instance, or catabolism, right? Have they had other diagnostic tests that evaluate nutritional status or cardiovascular health, right? Have they had a swallow study? Things like that, right? How physically active are they? This could be really, really important to when we talk about energy needs, right? What is their mobility? Are they able to cook for themselves, right? All considerations that influence nutrition. How is their appetite? Are there things, right, that could influence their nutritional intake? So whether that be their desire to eat, nausea, vomiting, right, that could influence that, or their ability to eat, right? Are they able to chew well? Are they able to swallow safely? And then, right, is there something going on with their gut? So all things, right, that can influence one's ability to have good nutrition. These are all important factors in this ABC part of the nutrition assessment. So here we want to inspect their chart. We want to write down observations that we make related to clinical or physical data. And then we want to gain more data from the client. So this is client history. We want to be asking them about other influences that could matter when it comes to nutrition. So what's going on with these factors? We can also get data from other places concerning their nutrition, concerning our client or patient, right? So we want to ask nursing staff, how have they been eating? What have they been eating? How much of their plate have they been eating? What are they like? Do they struggle? Nurses are on the floor with our clients, our patients the most. And so they will have observations that are super valuable to us. Social work might be important, especially when we're crafting appropriate nutrition interventions. Speech language pathologists, they help with chewing and swallowing, so they may have important insights for us. And then PTOT, this gives us insights into their mobility and ability to eat and cook for themselves. So again, we could glean some really, really important nutrition data from these guys. So I've discussed the nutrition focused physical exam. This is the one other way for us to collect assessment data. The NFPE we will practice in class, but essentially, right, this is our way to screen for malnutrition, but we can also screen for nutrient deficiencies through the nutrition focused physical exam. So what we want to do is, greet the client, ask for permission, but we want to assess them from head to toe using our eyes, but we can also do some physical measurements to get at nutritional status of the patient. So we want to include them, we want to get their input, but we can do a lot of things to assess nutritional status using the NFPE. So 4 steps, we're going head to toe, but first we want to make observations, right? So we want to look at coloration, we want to look at the size and texture, we want to use all of our senses when we are inspecting our clients or patient. We can do a hands-on exam. Again, we want to ask permission from the patient, but we can use our hands to assess different body measurements that will tell us about nutritional status. We can use percussions or sounds to help us understand nutritional status. And right, we can use our ears to hear for body sounds. Specifically, right, we might be listening to the GI tract to hear for bowel movements that could maybe give us more information about the gut and how well it's functioning. So NFPE is used a lot to assess fat loss and muscle loss. So here, right, we can use our eyes and do a hands-on physical exam to assess for changes in our different fat pads, right? So we're looking around the eyes. Are the eyes more hollow, or are there good fat pads around the eyes? Our buccal fat pads or our cheeks, are they sunken in or are they well pronounced? We can look in other areas, our triceps, our collarbone area, our ribs. These are all areas where we can look for significant fat loss. And then muscle loss, right? These are other things that we'll want to look at or do a hands-on exam to assess. But typically, right, if we're seeing severe malnutrition from these areas, these will be visually very obvious. But again, we're using all of our senses and potentially a hands-on approach to assess for changes in fat or muscle loss. And then again, we can evaluate malnutrition using a grip strength or a dynamometer. This can tell us about malnutrition or nutritional status as well. So, right, that's the ABCDs. A few other things when we're looking at charts, doing assessments, we really want to pay attention to changes in weight, but we also want to look for changes in fluid status and micronutrient deficiencies in labs. So when we're looking at weight changes, significant weight change is classified as 2% of a weight change over 1 week, 5% over 1 month. Typically, when we're interacting with clients, we have 3-month data. So if you see someone that's lost more than 7.5% of their body weight in the past 3 months, that would be considered significant. But these are the other standards, right, for what we would consider significant weight loss. So typically that's a category of malnutrition, but one way for us to think about weight change and weight change over time and what is significant versus what is considered maybe healthy weight loss for someone. When we're looking at charts, you'll often be able to look at someone's eyes and O's or inputs and outputs. This will give you an idea of fluid status. So our is all the liquid that's coming in going out, right? So what is happening is more water getting retained than is leaving. That's, we can look at different fluctuations of the I's and O's. We can also look for evidence of edema or fluid pooling, right? So is it pitting or not? This is something we'll practice with the nutrition focused physical exam, but that can also give us an idea on fluid status. And then from labs, we can glean labs and other deficiency symptoms that we will discover through the nutrition focused physical exam. Are there deficiencies at play, right? So when we're doing that last part, the D of the ABCDs of nutrition assessment, we want to be looking for dietary information. So we could ask the client what's normal, but right, we click this link. Right, normal is not a very descriptive word. So you will get a lot of different responses when you ask someone what normal eating means to them, right? So normal can mean that you're hungry and you eat till you're full. Perfect, right? But normal could also mean so many other things, right? Leaving cookies on the plate because you'll let yourself have cookies tomorrow. Could be overeating at times, and feeling stuffed and uncomfortable, but also undereating at times. So maybe what is normal for you isn't the best question, because you will get an array of normal. Normal for me could be different from normal from you, right? So when we're doing our dietary assessment, we want to be really targeted in the questions that we ask. 24-hour recall. What did you eat yesterday? This is appropriate, right? If they weren't in the hospital yesterday. But right, maybe what do you eat in a typical day? That could be another good way for us to understand what eating was like before the hospital and what eating is like now if they're in the hospital, right? We can also get dietary data from a chart. So nursing might record they ate this meal and they ate 50% of their plate. So that dietary data is also really good and important, right? We want to be asking about their nutrition history. Have they started dieting? Have they started eating more? Have they started eating more junk food or vegetables? Right? Are there different things that are happening throughout the year that changes their dietary intake? So all of these questions, they're pointed, they're not vague, like what is normal, right? They give us specific data that we can use in our diagnoses. And once we get all of this, right, then we can figure out, are they eating enough? So there's lots of ways for us to figure out how much energy or how many calories someone needs in a day. And this is really important for two reasons, right? So we want to protect or prevent malnutrition. So this is really, really important for dietitians in the hospital, these calculations, because we want to make sure that while they're in the hospital, they don't develop malnutrition. We're nutritionally meeting their needs. And so in order to know that, we need to calculate how much energy they need. But also, right, if we're counseling someone in a more like outpatient setting, we still want to make sure, right, we are giving them a nutrition intervention that's meeting all their needs, checking the boxes, and addressing maybe areas where they're either eating more than they need or less than they need. And so in order to know that, right, we have to figure out what their energy needs are based on a couple different factors that can help narrow down and individualize caloric needs for the patient or client you're working with. So there's a couple different ways to do this. But before, right, we want to think about what their weight is now and what it maybe ideally would be, so that we can make those energy estimations. So the ideal body weight, or IBW, is based on this Hambley equation. That's pretty easy math if you think about it, right? So for females, for every inch above 5 feet that female is, you take 5 times that inch amount and add it to 100. So if we're looking at a woman that is 5'6", right, her ideal body weight would be 100 plus 5 times 6. So 5 times 6 is 30. So that person's ideal body weight would be 130 pounds. And here's another example, right? 5'4", 5 times 4 is 20, and we add that to 100 to get the ideal body weight of 120 pounds. For males, the equation is just slightly more difficult because it's 106, and it's a 6 multiplier, but same thing applies, right? So if the male is 6'2", we take 106 plus 6 times 14, because 14 is the number of inches above 5 feet that 6'2" is, and that gives us an ideal body weight of 190 pounds. Depending on their frame, so are they a larger person or a smaller person naturally, like based on their body size, right? We would multiply this ideal body weight by 10% or reduce it by 10% depending on their frame size. So are they petite or are they on the bigger side of the equation? This would change their ideal body weight, right? So that's one factor that we want to consider before we estimate energy needs. Another thing that is useful to us is BMI. So BMI is mass divided by height in meters squared. So kilograms by meters squared. And so it's important to know how to calculate this, but there are calculators out there. So this is the NIH calculator. It makes it pretty simple. You just enter in the data. So if we still had that 5'4" woman, she weighs 120 pounds. It gives us the BMI of 20.6, right? So there's calculators out there. When you're charting in the real world, you'll use a calculator. But knowing generally, right, it's kilograms by meters squared, or weight in pounds divided by height in inches squared times 703. So remember this equation, and then remember these ranges. So BMI ranges, right, generally tell us about the category, a BMI category of the person, right? So under 18.5 is considered underweight. Normal weight is between 18.5 and 24.9 kilograms per meter squared. Overweight is between 25 and 29.9. And then anything over 30 is considered obese. Another thing to consider with dietary needs that is outside, right, of energy specifically is protein needs. So we really want to make sure we're providing enough protein to our patients. So generally we would prescribe protein within this range, 0.8 to 1.5. But depending on their disease state or what we've found from our other analyses or assessments, we may adjust this plus or minus based on their disease state. So again, with these energy equations, We may use their current weight, we may use their ideal body weight, right? But for males and females, the equations are slightly different, but we generally use the Mifflin-St. George equation, which is this one. So we consider weight in kilograms in this equation, height in centimeters in this equation, and their age to determine energy needs. Or we consider this standard calorie range, which is about 25 to 35 calories per kilogram. Notice this is not tailored for age, height, weight, or sex, right? But this is another calorie estimator that will help us determine energy needs for our patients. So, right, if we're trying to maintain that person's weight, maybe we're somewhere in the middle of that range. If we're trying to produce weight loss, maybe we're on the lower end of this range. And if we're trying to induce weight gain, maybe we're on the higher end of this range. So pause the video and calculate for yourself what is your energy needs based on Mifflin-St. George versus what is your energy needs based on this range? How are these equations producing different numbers? And then why would this matter, right, for the clinical setting? So pause your video and do that calculation. Okay, so looking at these differences, right? Interesting. So in the hospital setting, right, we can always adjust calorie needs. And so depending on what we use, we want to make sure we're getting the patient enough nutrition, and then we can observe and watch our clients or patients and modify the energy prescriptions that we've given based on what's going on. So that's again where trends are really, really important. But we want to be assessing dietary intake when we're talking with clients or assessing what they're currently doing as part of that nutrition assessment portion, right? So if we look at these numbers, we look at the range, and then we look at what they're normally eating, we can typically identify if that patient is not eating enough or eating a little more than their energy needs would be based on either or both of these equations. So they work, right? When we're doing these equations, we also basically are calculating energy needs for what we call our basal metabolism. So basal metabolic rate, this describes the energy required to keep us alive, right? So when we calculate, especially using Mifflin-St. George, we want to adjust this energy recommendation using an activity factor. So Mifflin-St. George will spit out our BMR, or how many calories are needed for us to lay in bed and stay alive. And then we would multiply that number by an activity factor that's based on the mobility or disease state of our client, right? So you'll see, right, sedentary, there is a multiplier. So we are increasing calories, even if that person or client is immobile. But then we increase the activity factor as activity changes and calorie needs increase. So TEE, right, total energy expenditure, we are making sure when we're making energy recommendations that we're not just looking at what the person needs to stay alive, we are looking at the energy recommendation for that individual patient that incorporates the energy needed for them to do their functions of daily living. So after we've collected all of that data, nutrition diagnosis is the next step in the NCP. So we are going to identify a nutrition problem And then we're going to use our assessment data to support that diagnosis, so that we can move forward into deciding an appropriate intervention. So for nutrition diagnosis, right, there is specific terminology that we want to use. And oftentimes, clients don't just come in with one problem. So when we are deciding what to do for our nutrition diagnosis, we want to identify the nutrition problem that is highest priority. And we want to make sure it's a nutrition problem that's nutrition related, that we as dietitians have influence over, right? So when we are doing a nutrition diagnosis, we use what's called a PES statement, where we are identifying a problem using specific diagnostic criteria. We are using something specific from our assessment to think about what is the cause of that problem. And then we're also using assessment data to identify what or how we know what is the cause of this problem. So the problem, the etiology, or where it came from, and what supports that etiology based on our assessment data. So when doing or writing a PES statement, we want to make sure that we are staying within our scope. We're choosing nutrition diagnoses that are truly nutrition related, because, right, with this example, we have assessed a client and they have high blood pressure, and they have identified with us that they consumed processed foods that are high in salt, right? Hypertension is a medical diagnosis. So do we have a lot of influence over that as dietitians? Maybe not. But as dietitians, maybe we can influence how much sodium they're taking in, which ultimately may help with their medical diagnosis of hypertension. So instead of identifying hypertension in our diagnosis, we may diagnose that patient with excessive sodium intake, right? That's a nutritional diagnosis. It's within our scope to intervene on that. So we would maybe select that and continue with our PES statement, right? So that's in a situation where maybe there's a medical diagnosis, but then there's a nutritional related thing that's going on that's leading to that medical diagnosis. We would err on the side of investigating and diagnosing the nutritional aspect versus the medical aspect to stay within our scope of practice and be able to intervene from the RD side. So on Moodle, there is the nutrition diagnostic language that we want to use, but within that sheet, there are 4 domains of nutrition diagnosis criteria. So we can diagnose someone with something related to nutritional intake, clinical data, behavioral or environmental data, or other. So if we take a look at, let's see, diagnostic terminology, I'm gonna have to really squint at this one. It's on the Moodle page though. We have things related to intake. So this could be increased energy expenditure. This could be inadequate oral intake. This could be excessive fluid intake. This could be malnutrition related, inadequate fat intake. The list goes on and on, right? So nutritional intake is one category. Then we have clinical data. So this could be swallowing difficulty, right? Biochemical data. So let's see, what does that say? Impaired nutrient utilization. And then behavioral environmental. So this could be related to the patient doesn't know how to follow a diabetic diet, and that's why they're not doing it, right? And then other is there isn't a nutrition diagnosis at this time, right? So we want to, and we need to use this diagnostic criteria when writing our nutrition diagnoses. And typically they fall within one of these domains. Most commonly, right, we're going to get nutrition diagnoses within the nutrition intake domain, but we can pick any criteria based on the individual patient, right? So again, nutritional intake category, we're looking at changes in energy balance potentially, changes in oral intake or nutrition support, changes in fluid, supplement use, and then specific nutrients. So has something with any of the things that go into your body changed that has led to a nutrition problem, right? With our clinical data, we also are looking at functional things that might be happening that impact nutrition, biochemical data, and weight. With the behavioral environmental, right, a lot of this is knowledge deficits or beliefs, but could also be related to access or safety. And then again, the last category is that there's no nutrition diagnosis at this time. So diagnosis tips, right? How do we do this? So again, people are complex. Typically, there's going to be more than one problem. But again, we want to be picking the one that is most impressing, most important, which is highest priority nutrition-related problem. So we want to pick it. We want to use the diagnostic terminology, and we want to use nutritional data to support this diagnosis in our PES statements. So once we've narrowed down what we want as our nutrition diagnostics term, we move on right to writing our PES statement. So let's think of an example, right? So when we do our assessment, we have assessed 2 patients. We want to be thinking, what's the nutrition problem? What's the cause or etiology? And what are some supporting data that we can use to support this diagnosis, right? So here's Sue and there's Steve. Sue has cancer, which is a catabolic chronic condition that can lead to different nutritional problems, right? And then there's Steve. Steve is a highly active guy. He's increased his activity to support marathon training, right? So he's got a lot of things going on too that could impact his nutritional status. So when we're thinking about diagnoses, right, I'm thinking, right, there might be some intake issues with these guys, right? So going to the nutritional intake category, and there is maybe an energy balance. There's an energy balance category where for Steve, he has increased energy expenditure. He is burning a lot of calories doing activities, marathon training, where for Sue, she might not be getting enough energy in, right? She might be nauseous or have lost appetite because of cancer, where inadequate energy intake could be a concern for Sue. So these are nutrition intake diagnoses that we could apply to Sue and Steve. When writing our PES statement then for Sue, we take an adequate energy intake, which is a diagnostic term straight from the terminology sheet. Notice that we have the identifier code included in our PES statement. So inadequate energy intake, which is in the category of nutritional intake 1.2. And then we write related to, where we list the etiology. So for Sue, her etiology is prolonged catabolic illness, aka cancer, and decreased ability to consume sufficient energy. So her disease is catabolic, meaning there's a lot of calories being burned because of the cancer. If she had loss of appetite, right, we might put that in here too. And then we use and support our PES statement with our data. So as evidenced by, and then we list our data that we have on Sue. So for Sue, we write reports or observations of less than 50% of normal intake in the last 3 weeks, weight loss of 5 pounds over the last 3 weeks, and food avoidance or loss of interest in food, and poor dentition or oral health. So these are all things that we would collect from the nutrition assessment portion of ADIME, and we would use it for our diagnosis. So that's Sue. For Steve, our diagnosis might be slightly different, right? So he's training for a marathon, but he has predicted inadequate energy intake. And again, we list the identifier code within the nutrition terminology. And then his predicted inadequate energy intake is related to anticipated change in physical demand or leisure activities, as evidenced by, so what's the data? Reports or observations of projected increase in physical activity, weight loss of 5 pounds over the last 3 weeks, and client reported lack of food preparation skills. So these are all evidence of why this all might be happening to Steve. So these are 2 examples of PES statements, right? And there's way more examples of this. Let's see. And other resources on Moodle. So here I have more PES statements that maybe are written per different category within the diagnostic terminology. So this is for an intake domain, the clinical domain, all these different PES statements to help us get proficient in thinking about different ways that we can write about nutrition diagnoses. Okay. The next step in ADIME is nutrition intervention. And this is the strategy in which we will approach the nutrition diagnosis. So it needs to be appropriate, it needs to address the nutrition diagnosis, and there needs to be a course of action. So some considerations when thinking of a nutrition intervention is what are some common ideas or tips? What is the patient willing to do? So that gets at the appropriateness of the nutrition intervention. And then does this intervention address the diagnosis that you've given, or does it meet that goal? So if we're going back to our example with Sue and Steve, for Sue, a nutrition intervention that is relevant, appropriate, and addresses the diagnosis, Sue might be offered high-calorie, high-protein snacks to help address some of her inadequate intake diagnoses. She could be encouraged to have smaller, more frequent meals, and she could be offered feeding assistance since dentition was a concern. And for Steve, we will again offer him high-calorie, high-protein snacks to help with the energy intake concern. And then we might brainstorm some meals that require minimal effort since cooking was also a concern for Steve. And then finally, the last portion of ADIME is the ME, the monitoring and evaluation. So right here, we want to determine what data we're going to track, how we are going to determine if goals are being met, and what we will continue to monitor, right? So can we monitor appetite, weight, assistance, tolerance of the diet, etc.? And then what is the time frame? So when will we assess, when will we relook at these things to determine if that goal was achieved? So it could be as needed, it could be per patient request, it could be in a certain time frame. It all depends on the setting you're in, the follow-up policies and procedures, things like that. So last but not least, I'd like us to now practice. So at the end of this video, I hope that you are able to go through the ADIME process for this patient, for Sarah. Look at the data we have on Sarah, and then figure out, give her a nutrition diagnosis. So if we take a look, we are looking at the anthropometrics, the B, the ABCDs of assessment, what's going on with her what is the nutrition problem here that we can address? And then, and these slides are available on Moodle, so you can refer back to them, right? But if we're looking at Sarah, right, maybe we want to calculate a BMI for Sarah. If we use our Hamley equation, right, we know that the ideal body weight for someone that's 5'4" is 120 pounds. So knowing that her weight is 185 pounds, this is above the ideal body weight for Sarah. If we look at her labs, maybe she has, and we see the arrows, right? She has high blood glucose, high cholesterol, high triglycerides, and high blood pressure. So maybe there's some cardiovascular concerns for Sarah. She is struggling to lose weight. She's a mother. She works full time, but has maybe a sedentary or maybe sedentary job. She works as a floor clerk in the hospital. And then we're going to evaluate her dietary intake, right? So look at what she's eating. We can maybe do a rough estimate, like, is this enough? We can calculate her energy needs. So, like, what's 25 times 120 pounds? What's 35 times 120 pounds? That'll give us that calorie range. Is she meeting that with this diet? Is she over consuming? Is she under consuming? And then, right, her only physical activity is running after her kids. So that can help us decide if we need to apply an activity factor or not. And then based on this assessment, right, then we can write some PES statements. So when you're done, pause the video, look back at the slide, assess Sarah, and then prepare some PES statements, do some practice. It doesn't hurt. And yes, that's you using the nutrition care process. So hopefully that we have learned a little bit about what that process is, how to apply it, why it's important.